morning, everybody. Welcome to this session on new aspects in the field of renal denervation, and we will have interesting details provided by the speaker with some discussion. We'll have maybe a short discussion after each talk, just burning question, and a final panel discussion at the end. And let me have my welcome slides, if you don't mind, please. Oh, this is the polling. You should use this QR code to answer a few questions that will be posed during the session. One will be at the beginning, one will be in the end, and then we will see the answer straight away on the screen. So please take a shot of this. So if you have already downloaded the ESH annual meeting app, you will find all the instructions there. Okay, let's move. So we are discussing now some progress in the treatment of uncontrolled hypertension. What is the scenario we are facing? Next, please. This is a projection to 2040, and these are the years of life lost due to a number of possible causes. And no doubt you see clearly here, high blood pressure is number one factor responsible for millions of years of life lost, which is followed by obesity, smoking, diabetes, but high blood pressure clearly is the most damaging and risky factor. And next, once you have this in your hands, the next question is, how can we control it? And again, we know that controlled hypertension is far from being satisfactory. These are data from Paul Muntner from US in 2018. You find that the rate of control of hypertension was increasing slightly up to 2013, then it was declining, and in the last evaluation they did, they had a 45% control rate, which means that 55% of hypertensive are still uncontrolled, in spite of the technology, the number of drugs we have, of all the meetings we are having like this one, but we are still unable to reach a satisfactory control rate. Next, please. There are several possible reasons for that, as you know very well. One of them, undoubtedly, is the poor adherence of our patients to long-term treatment. Here you find a calculation of what could be the percentage of patients adherent over time, considering roughly 1 year since the first prescription. And you find that in less than 1 year from the prescription, you see that 50% of patients are not adherent. That's a major problem, obviously, if you want to reduce the mortality, the morbidity associated with high blood pressure. Next, and that's the question. What is your perception? These are data collected in studies, but what's your personal feeling of the real percentage of patients with uncontrolled hypertension? You can use the app to vote. You can select between 15-25%, between 25 to 40%, or more than 40%. Please give us your opinion, your feeling, what you think is the case. We should see the results in a few seconds, hopefully. That's just a starting point, to have a common background on which we can build our discussion today. Okay, so the majority thinks that we have more than 40%, so you in a way agree with the data of the studies, and that's definitely the common experience of all of us here. So we start from this point now and try to go deeper into some possibilities offered by modern technology. And it's my pleasure now to introduce the first speaker, Professor Kostas Tsioufis, the president of this Congress. I want to congratulate Kostas for the success of this hybrid meeting. It's really unexpected in a way to have so many people participating. And Professor Tsioufis will tell us what do the latest guidelines say on this possibility of progress in treatment thanks to renal denervation. Please, Kostas.
Thank you, Gianfranco. Good morning. Good afternoon for those being connected outside Europe. Dear colleagues, this is my conflict of interest. And before answer, let's say, to the point that I have to discuss today, let me remind that essential hypertension, we all know that it's a multifactorial disease where many factors participate in its pathogenesis, environmental factors and genetic factors, factors related to hemodynamics and to vascular function. But everyone agrees that neurohumoral activation, including sympathetic nervous system activity and renin-angiotensin system activity, has a major role. For this reason, therapies targeting sympathetic nervous system have been introduced for the therapy of hypertension very early. In the decade of 30, surgical sympathectomy was performed for the therapy of malignant hypertension with good results. About 60–70% of those patients were responders to surgical sympathectomy, but as you know, this method was abandoned due to side effects. And later, in the decades of 50, we have the first antihypertensive drugs, which was reserpine and gluconic blockers, and later the successful introduction of beta blockers, alpha blockers. And in the last decade, we have the introduction of renal denervation by delivering energy with disrupt the renal sympathetic fibers. This is the pathophysiological background for renal denervation. Kidneys are very rich innervated by efferent and afferent fibers. In case of renal hypoxia, ischemia, through the afferent fibers, there is this activity is transferred to the central nervous system, and then through the efferent fibers, this activity, increased activity, does not only go back only to the kidney, promoting the renin secretion, the sodium precipitation, and also reducing the renal blood flow, but also go to the vessels, causing vasoconstrictions, and to the heart, promoting left ventricular hypertrophy and arrhythmiogenesis. By renal denervation, we disrupt the efferent and afferent sympathetic fibers, and focusing on the kidney, we modulate the kidney-brain interaction. Having this favorable pathophysiological background, in HTN in 2014, we have the first randomized controlled trial, the HTN-3, which failed to meet its primary efficacy endpoint, and this failure led to changes to the method for future renal denervation, some controlled trials. The next second generation renal denervation studies trying to incorporate many of these confounders that have been considered for the failure of HTN-3. Better design of the studies, including changes in ABPM or home blood pressure measurements instead of office blood pressure changes as a primary endpoint. Stricter inclusion criteria with assessment of medication adherence in order to eliminate the blood pressure variability post-renal denervation, and also improvement in the ablation algorithm for disrupting the renal sympathetic fibers. And in this slide, we see the consistent results regarding office and ABPM blood pressure reduction in a various spectrum of hypertensive patients, naive of antihypertensive medication, or in patients receiving 1, 2, 3, or more medication, and also by using different modalities to disrupt the renal fibers, intravascular ultrasound, or radiofrequency energy. And in all this, it is interesting to see that we have consistent results in blood pressure reduction. And we know from the pharma trials that this statistically significant blood pressure reduction of at least 5 to 8 millimeters of mercury in ambulatory systolic blood pressure could be translated in a clinically important reduction of cardiovascular event by 10 to 15% in the major cardiovascular event. So, based on this very solid evidence about the efficacy and safety of renal denervation all these last 4 or 5 years, and all different scientific societies across the world try to identify the potential indications of renal denervation, how to put renal denervation in the clinical pathways for managing hypertension. And in 2018, we see here that we have the publication of the RADIANCE-HTN solo and the RADIANCE-HTN study. In 2020, the spiral HTN of pivotal study. 2021, the RADIANCE-HTN trio study, and in 2022, we expect the RADIANCE-2 pivotal study. And at the same time, different societies produced consensus statements. All these consensus statements agree that renal denervation lowers ambulatory and office blood pressure significantly. Indeed, in the last year, 3 position papers were published by from European Society of Hypertension, from the Spanish Hypertension Society, from the Society for Cardiac Angiography Intervention in relation with the National Kidney Foundation, and also from German experts. And all this agree that renal denervation is a safe and effective evidence-based option to treat hypertension. I will focus only, we are in the European Society of Hypertension meeting, where I will focus only in this position paper produced by Roland Spicker on behalf of the working group on interventional therapy in the European Society of Hypertension. And here are the key messages of this position paper. Renal denervation represents an evidence-based option to treat hypertension in addition to lifestyle changes and blood pressure lowering drugs. Renal denervation expands therapeutic options to address the first objective of hypertension treatment, which is to effectively reduce elevated blood pressure and achieve blood pressure targets. Of course, renal denervation is considered as a safe endovascular procedure without significant short-term or long-term adverse effects based on data available to 3 years. Renal denervation, and this is very, very important statement, renal denervation should be considered as an alternative or additive treatment strategy and not as a competitive strategy to antihypertension medication. A structural pathway for clinical use of renal denervation in daily practice is recommended. Patient perspective, preference, and stage of hypertension disease, including comorbidities, should lead to an individualized treatment strategy in a shared decision-making process that carefully includes the various options of hypertension treatment, including renal denervation. In a shared decision-making, the first step is clinicians to provide the best available evidence for all these treatment options, including the risk and the benefits of each option. In parallel way, treatment and care options take into consideration individual values and preference, and a collaborative decision about treatment or care is documented and shared with relevant stakeholders. So, in summary, let's see here what these position papers recommend about ideal profiles of hypertensive patients to be treated with renal denervation. All these papers agree that patients with uncontrolled hypertension, patients with resistant hypertension, patients with non-adherent to drugs or intolerant to drugs, as well as hypertensive patients at high cardiovascular risk with severe target organ damage should be considered candidates for renal denervation. Of course, renal denervation could be applied in associated conditions with hypertension with increased sympathetic activity like heart failure, atrial fibrillation, chronic kidney disease, but now we are collecting data for these conditions. So, in the same line, I am happy to present here an investigator-initiated study that we are doing in my department. In hypertensive patients with anxiety, we try to see what should be the effect of renal denervation in these patients with uncontrolled hypertension. So, dear colleagues and ladies and gentlemen, in light of these data, solid evidence that renal denervation is efficacious and safe intervention for treating uncontrolled hypertension, I am sure that the next edition of guidelines will include renal denervation as a part of combination strategies to meet blood pressure goals, along with diet, with exercise, and combination drug therapy. With that, I would like to thank you all for your attention.
Thank you, Kostas, for this excellent summary. Is there any burning question on this talk? Just a curiosity, you were mentioning the effects of renal denervation on ambulatory blood pressure in the recent trials. There is then evidence that also nocturnal hypertension can be controlled. That's one of the issues we're discussing in this Congress.
Thank you. Nocturnal hypertension, no question, has an important and independent prognostic impact. And we know that renal denervation, there are published data that has an homogeneous, produce an homogeneous reduction in blood pressure during the daytime and nighttime period. And it seems, based on preliminary data, that effectively, preferentially reduce the blood pressure during the nighttime period. So this is one more reason, one more, let's say, indication for using renal denervation for those patients with increased nocturnal blood pressure.
Which remains a pending issue, that it's necessary to have new approaches to improve nocturnal blood pressure control. Yes. And another important issue I like very much is what you said on the need to consider renal denervation as part of a combined approach. It's not a magic intervention solving everything. That's one of the mistakes in the early phases. But it's something that combined with the other treatment might really help a lot controlling.
I think it's very simple. We suggest in every hypertensive patient lifestyle changes. No question about the effective role of that, but we all know that this is not, for many reasons, patients cannot be able to follow that for long term. Then we have antihypertensive medication, safe, well-working antihypertensive drugs, but also there are patients, for many reasons, that drugs are ineffective. We have something to offer to them. And I think renal denervation is a nice therapeutic option because now we have the evidence that renal denervation works.
Thank you, Kostas, for your excellent talk. And we move to the second speaker, Professor Michel Azizi, who is going to tell us the latest clinical data on ultrasound-based renal denervation. Michel.
Thank you very much, and hello to everyone, dear colleagues, and thank you, Gianfranco. So I will just focus specifically on ultrasound renal denervation here on behalf of my co-PI, Ajay Kirtane from New York. So these are my disclosures. So to move quickly, to remind you what is this technology using ultrasound, you see here the probe inside the renal artery, which is going to emit ultrasound waves, which make an ablation. This is a thermal ablation. This is ultrasonic aging of the renal nerves, which are in the adventitia of the renal arteries. And this is embedded inside the cooling balloon to avoid the damage of the endothelial and the media of the artery. And as you see, 2 or 3 sonications of 7 seconds, are delivered in each main renal artery. So this is the global clinical program. I will very quickly go through this. These are the first studies, feasibility studies. These are the randomized controlled trials, and these have been completed. This is just the recruitment has been finished, and we hope, as Kostas said, that in 2022 the data will be presented. And this is a Japanese randomized controlled trial. And new programs are also being set, and this will be shown by Roland Schmieder later on. So in the RADIANCE-HTN studies, we assess the effect of ultrasound renal denervation in patients off medication in the RADIANCE solo trial, and on medication, and specifically in patients with so-called resistant hypertension. So as you can see here, the design of both studies was very similar. So here we had 4 weeks of washout of antihypertensive medication if they were already present on 0 to 2 antihypertensive medication. And here we switch patient to a single pill, triple combination therapy as recommended by guidelines. And this was hydrochlorothiazide 25, an angiotensin II antagonist, which could be valsartan 160 or olmesartan 40, and amlodipine 10 milligram. So in each case, we also confirmed that the hypertension was either present still or there was resistant hypertension by an ambulatory blood pressure monitoring, and this was the average value which patients should have in the morning above 135 over 85 millimeters of mercury. After checking the anatomical eligibility, patients were randomized in the cath lab to ultrasound renal denervation or a sham procedure. So the primary efficacy endpoint was at 2 months, and what is very important is that patients and physicians following patients and output assessor were maintained completely blinded to the randomization, and no blood pressure medications were authorized except if blood pressure criteria were exceeded. And we have follow-up up to 6 months, and also we will show you the 6 months blood pressure lowering effects of these drugs. So these are the primary endpoint results. This is at 2 months for the solo trial and the trio trial. As you can see, we have a drop in blood pressure, ambulatory blood pressure of minus 8.5 millimeters of mercury in the renal denervation group against 2.2 millimeters of mercury in the sham group, and the between difference is minus 6 millimeters of mercury systolic blood pressure. This is very similar in the trio trial, minus 8 millimeters of mercury, minus 3 in the sham group, and the between difference is minus 4.8 millimeters of mercury. So very similar effect in those without medication and those on a triple medication therapy. So after the 2 months endpoint was ascertained, patients were given antihypertensive medication on the basis of their home blood pressure level. So we should achieve the home blood pressure control, and these medications were added blinded to the randomization scheme. So there are different medication protocol, and specifically in the trio trial, we added spironolactone as a fourth-line therapy. So please keep in mind this, then the beta blocker, centrally acting medications, alpha blockers, etc. So after 6 months follow-up in the blinded way, we analyzed medication burden and ambulatory and home and blood pressure. So in terms of medication, so this is solo trial and trio trial. Green means you have the same number of medication, and orange dark shows you that you have added up to 3 medication, and you clearly see quickly that the patients in the denervation arm had less medication added than in the sham arm. And specifically, if we look to the trio trial, you see the aldosterone antagonist use was much lower in the denervation group, 40% against 61% in the sham group, with a difference which was highly statistically significant. Physicians were blinded to the randomization. Keep this always in mind. In terms of ambulatory blood pressure monitoring, this is the RADIANCE solo trial. So what Costas said, and also Gianfranco, that you have a nocturnal blood pressure lowering is obvious here. This is the denervation group, and you see this is the 2 months effect. So blood pressure lowering is obvious and absolutely confirmed here. And you see this always-on effect that during daytime and nighttime blood pressure, blood pressure is lowered. And if you look after 6 months, after adding some medication, still this effect is present, and it's even larger than what has been observed here in the sham group. And the difference between the two groups remains significant after adjusting on the number of antihypertensive medication. So we move now to the trio trial. This is what we observed after 6 months. Since, as you can see, there is no rebound hypertension or something escape. So nothing happens after 6 months. despite patients receiving less antihypertensive medication, and the drop in blood pressure is minus 12 millimeters of mercury in ambulatory blood pressure. So if we look to what happened in the sham group, adding medication, yes, has an efficacy. So we had also a 12 millimeters of mercury drop in blood pressure. So the difference between the two groups was no more significant because of this addition of much more medication, and specifically aldosterone antagonists. But if we look to the home blood pressure changes, here are home systolic blood pressure changes, as you can see, the home blood pressure specifically has a greater sensitivity to find the difference, the persistence of the difference between the two groups of 4.3 millimeters of mercury, whereas, as you can see, patients in the denervation group were always less treated by aldosterone antagonists than those in the sham group. So there is a persistence, at least after 6 months follow-up, of the blood pressure lowering effect of renal denervation. So we could, because of the similarity of the trials, we pooled and we did a meta-analysis, individual patient meta-analysis of all the data. So there was no heterogeneity in the effect on daytime ABPM, home blood pressure, and medication. So the changes in medication are highly statistically significant in favor of renal denervation. Less meds were added. And if we look now, the drop in ambulatory blood pressure and the drop in home blood pressure, that there is always around 5 millimeters of mercury systolic blood pressure difference, which is highly statistically significant all during the 6 months follow-up. So So if we look also the complications or the safety data, these are the pooled data. You can see there are very few events. Some stroke and acute MI occurred in TRIO trial, because these are high-risk patients, but there are no safety issues related to renal denervation. This slide shows you now the 24 months data in this RADIANCE solo trial. So as you can see here, there is a prolonged blood pressure lowering effect of renal denervation. And you see here that there is no changes, or almost no changes in antihypertensive medications. So we don't show the sham group because there are a lot of crossover, more than 60% of the patient crossed over. So here that's only the single arm of RADIANCE-HTN solo. So if we put on a single slide all the data that we have gathered here with renal denervation, with ultrasound renal denervation, you have all these different trials using 0 to 2 antihypertensive medication which were stopped, or 3 and more antihypertensive medication that have been used in these different trials. And you see that there is a homogeneity of the drop in ABPM for each of these trials. So this is also very important, that when you want to generate evidence, you have consistent as a result from one independent trial to another trial. So we have this consistency, which is very important, confirming the drop in blood pressure. So if we put in perspective this drop in blood pressure in these trials, like Kostas Soufis showed you, here for 10 millimeters of mercury, and not 5, but 10 millimeters of mercury, this meta-analysis, which was published slightly before, you see the relative risk reduction that we should expect with this drop in blood pressure in terms of cardiovascular events, in terms of mortality, coronary heart disease, stroke, heart failure, and chronic kidney disease. So if it's maintained, and it seems that truly it is maintained, and data from Felix Mahfoud have shown that after 36 months still we can find a difference between groups and in favor of renal denervation, this is an extremely important information. So to conclude, the pooled patient-level analysis of our 2 trials have shown at 6 months that the between-group difference favoring the denervation over sham was around 5 millimeters of mercury in terms of daytime ambulatory systolic blood pressure and home systolic blood pressure. It suggests that the response to ultrasound renal denervation is consistent across different severities of hypertension, similar in the presence and the absence of medications. The durability of the blood pressure lowering effect on the long term was also reported in other observational studies, and the results of RADIANCE-2 as well as contingent access studies and registers of ultrasound renal denervation will be reported in the near future. With this, I thank you for your attention.
Thank you, Michel, for this very clear summary. I was really impressed also by the observational data on the long-term effects, which is quite reassuring, in this particular setting. But you provided us with a very interesting demonstration of the usefulness of home blood pressure in a clinical trial. And that's something interesting to consider for the future, because it's repeatable without too many problems. And as you showed, has a nice degree of agreement also with the ABPM data. What was your feeling in this regard?
Yes, because we trained, as you know, we trained all the patients really to adhere to a strict protocol of home blood pressure monitoring. And this reduced really the variability around the signal, because the ABPM was done at different times, 6 months between. So even standardizing this was much more variable, in fact, and this is also contributed to the fact that there was lowering the decrease in the difference between the two groups. And I really think that home blood pressure, and this has been also already shown by Sergio, showing that for clinical trials, you need less patients because of this better reproducibility and less variability, less patients to be included in trial to demonstrate a difference, a between group difference. And I truly think that it should be included in all these trials. And in the registry, as Roland will show, it's also will be present.
Yeah, this is in line, we remember, with our first studies on ABPM many years ago. Paolo, you may remember, and we started, and that was a clear demonstration that ABPM allows a reduction in the sample size because of the reproducibility. Home blood pressure is doing the same with the advantage of the easy applicability and acceptability, which is something. Any other question, please? We don't have microphones. Oh, there is a mic here.
Two questions. First, why did you choose daytime blood pressure as your main outcome? 24 hours would have been more comprehensive, and nighttime, many of us believe, is more important. And the second question regards the trio drug schedule. You begin with a beta blocker?
No, with the spiral.
With
spironolactone. We begin with the spironolactone.
Okay. And then beta blocker. And then when peripheral sympathetic system is blocked, you add a central blocker. And then an alpha blocker. So there seems to me there is sort of a redundance that reduces the efficacy of the treatment.
So for the first question concerning ABPM, daytime ABPM, you may remember that we used daytime ABPM for the RADIANCE-HTN study, and which was the basis of the calculation of the sample size. So, and indeed, a daytime ABPM has a higher level, so we wanted to detect more easily the drop in blood pressure. And in fact, it's also associated with prognosis, the daytime ambulatory blood pressure. So in a secondary endpoint, we looked at a 24-hour ABPM, which was by definition, as you see, the daytime and the nighttime drop in blood pressure was perfectly, significantly different. As to the drug institution protocol, so we use guidelines. The first step is to use spiroaldosterone antagonists. So this is the first step. And then the guideline says, okay, you can add all the medication you have, and all the medication you have is beta blockers, and then you have centrally acting antihypertensive drugs and alpha blockers. What we did here was a sequential inhibition of the sympathetic nervous system, because this sequence is a sequential to see whether we had left some activity of the sympathetic nervous system. So it was also pharmacologically and pathophysiologically driven. But the majority of patients and physicians did not go up to this. This was a recommended treatment protocol, but they didn't use, they stopped at the beta blocker, almost never or really rarely added the centrally acting antihypertensive medications.
Thank you, Michel. We proceed with the next speaker, Professor Roland Schmieder, who is going to give us additional indications on the ultrasound-based renal innervation. And Roland, you will talk about ultrasound technology and some key insight from the RADIANCE-HTN Clinical Program, please.
Chair Franke, thank you, dear colleagues. I would also like to thank the organizers for inviting me. And we have heard a lot already about the ultrasound renal denervation. I will extend it a little bit, also making some personal comments on certain issues which I think are still debatable. So these are my disclosures, and I would like to start with this slide you have already seen. We have these prospectively powered randomized controlled clinical trials in patients without any antihypertensive drug, in patients with a single pill combination. I think that's very good that we have it across a broader spectrum of the hypertensive stages. And we are waiting the results of the RADIANCE-2 pivotal trial, which I think is important and extends our knowledge in patients without any antihypertensive agent. The RADIANCE-HTN trial is a specific trial carried out in Japan and South Korea. They just started, so we have to wait a little bit for their results. Now, I just had the privilege to chair a session on research reproducibility by Professor Ioannidis from Stanford. Very nice presentation, very impressive. And I think looking at these data here, that we have not only by RADIANCE-HTN solo, but also by RADIANCE trio, 2 other trials, also randomized sham-controlled trials done with a different device, but also targeting the renal nerves and its consequences. I think we can really have a very solid evidence based on these 4 independent sham-controlled trials and covering now 693 patients. And with the upcoming spiral on and the RADIANCE-2, I think we will cross the 1,000 border. I have not calculated, but we are then pretty much to 1,000 patients, which I think give us a solid basis and confidence that renal denervation indeed lowers blood pressure. Most importantly, and also from all data we have seen so far, there is no increased safety risk that has been observed. I can extend that during the discussion. I do not want to waste time for that. Now, what is the new programs? And I think with all these randomized controlled clinical trials, we have a specific population, and we know how hard sometimes it is to get patients included into trial. We have now the Global Paradise Simplicity Registry, and we have a focus on RADIANCE prefer. I will talk a little bit about that as well. The DuoCrep, an extension for the TRIO study. And of course, now we are on the edge in science, not in clinical practice, to go beyond the indication for primary hypertension. Now, RADIANCE-2 study design is here. I want not to go into detail. I think Michel Assisi did it for the solo and the trio trials. It's just following the same route, the same pathway, and the endpoint is also after 2 months and based on daytime ambulatory systolic blood pressure. Patients were off any medication and randomized as depicted here, and it's planned to have also a long-term follow-up, and this time going really up to 5 years, not just to 2 or 3 years. I think this is an important step forward. Randomization is 2-to-1. This gives us maybe an opportunity also to look again whether there are certain predictive clinical parameters that determine the response in blood pressure. The GPS, the Global Paradise System Registry, is important in terms of safety, in terms of efficacy in the real world. And so just working on randomized controlled clinical trials That is important. It's a proof of the method, a proof of the concept, a proof of the intervention. But the question, of course, is can this one-to-one translate it into clinical practice with respect to safety and effectiveness? You can see here the targeted size of 3,000 patients, 200 sites globally, worldwide, 5 years post-procedure follow-up data will be obtained. And I think we already discussed on that, but this important specific feature is that home blood pressure measurements have been included. And I think this is important. I think, Gianfranco, you are very happy that this is included in this global registry, and I am too, frankly. Because with all the advantages of a 24-hour ambulatory blood pressure monitoring, it just captures 1 day. And I always see some colleagues talking about dipping and non-dipping. Well, you look at the papers in European Heart Journal, see that white coat hypertension or masked hypertension, in other words, the reproducibility of dipping is about 2/3. Now, would you rely on a biochemical parameter where the next time you have only a reproducibility of 2/3? I wouldn't do so much. So 24-hour blood pressure is important if you go to individual basis. If you have populations with hundreds of patients, that's no problem at all, because then it's balanced. And if you're sham-controlled, also no problem, or placebo-controlled. But in a single patient sitting in front of you, really talking about dipping, non-dipping, I don't do that any longer. I'm very cautious on that, making an individual, personalized conclusion on the patient sitting in front of me. So with home blood measurement, capturing a whole week, morning, evening, standardized protocol, techniques which have been certified by societies, I think this is a good step forward. It captures more about the blood pressure load on the cardiovascular system, on the renal system, on the cardiac system, and also on the cerebrovascular system. So I think it is a big step forward to have here a lot of data, and it's a very nice and a modern technology. It is automatically the data transported to the data cloud, and thereby I think we do not rely that a patient is prescribing a number, which is already a step which most patients even don't succeed to write down the numbers or invent some numbers. Oh, I forgot to write it down, and all these kind of tricks, which self-protocols really is not the way we should do clinical studies. And this brings up the issue about the patient. And you know, when I first got confronted to this issue, I was very glad to hear that the FDA required to focus on patient preference, to have this as part of the package to get approval for the renal denervation as an antihypertensive treatment. And so patient preference also has been now recognized by authorities that this is an important step. And I want to show you why this is so important, because patients might have a different view on a therapeutic option as we doctors have. It's discrepant. Patient preference needs to be incorporated in our decision, which is the best treatment option for our patient. Now, this is a survey done in US and Europe, and it's a summarized survey, and it tells you what you would expect. If we have a higher blood pressure, the red color means, yes, the physicians are more prone to recommend renal denervation as a therapeutic intervention and a therapeutic option. And this is irrespective whether we talk about referring physicians or the proceduralist. And then on the x-axis also, the stage of the disease is important, simply captured by the numbers of antihypertensive drugs, but also, of course, by hypertension-mediated organ damage. So the more severe and advanced the disease is, the physicians and the interventionists are more prone to recommend renal denervation. But about the patient, we would think it's the same. Simply, it's not at all. Look at these numbers here from the same survey. Blood pressure 140, 149, going up to 180. The number of patients who would prefer renal denervation is between 42 or 40 and 47%, irrespective of the level of blood pressure. And on the right side, also irrespective whether patients are on 3, 4, 5 meds, it is something around 50%. So patients have a different perspective what may be the right choice for them, that blood pressure is controlled. And I think this is an important message when we talk about renal denervation to our patients and in clinical practice. Finally, adherence. You have seen this slide throughout this conference the last 2 days, I think. I'm quite sure about that, talking about non-adherence. And it's between 17 for full non-adherence to 44% on average for the partial non-adherence. Now, non-adherence means on one hand side, of course, maybe the patient has not got the idea that high blood pressure is really dangerous for his health. He can get a stroke, disabling stroke, or dementia. So this is one thing. So if you have maybe educate the patient, you can overcome non-adherence. By the way, there is no study on that that has proven what I'm saying. It's just our belief that we can do that. On the other hand, we also may think about that non-adherence is a perspective, let's say a reflection of the patient, what he thinks about drugs. He may be afraid of side effects, of long-term safety issues, and we have also now these new tools to measure non-adherence by urinary toxicological measurements of the drugs that should the patient take according to our prescription. And these are the numbers here. Surprisingly, a lot of patients don't take any medication despite so nice drugs have been prescribed, even single pill combinations. They are not taking it. And this is really some kind of, let's say, you cannot say unwilling of the patient, or let's say he don't want to have that. And there, I think, real innovation comes in, because this is an overcome of that long-time side effects and these serious concerns of the patient. So I think non-adherence is also an expression of non-willing to take the drugs due to certain reasons which the patient has his own preference. So that's why in the shared decision-making process is important. We stated that in our guidelines. It has been already mentioned. And I want to just to go at the end. I think my choice, because I have shown the nice guidelines, I think those who are not controlled despite drug therapy, I think these are patients who are uncontrolled also on single pill combinations, stage 2 and 3. We need to talk about patient preference, and we should discuss also the non-adherence issue as an expression of not willing to take the drugs. So at the end, what is next? Allow me my personal view as a nephrologist. What I think is next is we should focus on chronic kidney disease. This is a very nice summary from Guido Grassi, the incoming president of this society, who have shown that if we have a decrease in eGFR, we have an increase of the sympathetic nerve overactivity. And so far, looking at the worldwide basis, we have 3 pilot studies found less decline or even a stop of the eGFR decline in patients with CK stage 3-1. We did one in Erlangen, one has been done in Melbourne, and one has been done in Sao Paulo, all coming to the same conclusion: not randomized, controlled but not randomized studies, and not sham-controlled studies, that there might be a great space for renal denervation to stop the progression of loss of renal function. And this is on the basis that we have, according to the GPRS registry, a similar decrease in blood pressure, but clearly safety is limited. eGFR was excluded if it's below 45 and 40, depending on what kind of device you are using. And thereby there's a potential use. And the next step, of course, is to do a randomized controlled clinical trials. We did initiated trials in Germany with universities. And I think actually from a theoretical point of view, we have a win situation. Reduce blood pressure, this should reduce the renal progression. Reduce the specific activity of the sympathetic nerves to the kidney. This, if we tackle that and we interrupt this tract, we should also have a less decline of renal function. So let's see. With that, I would like to thank you.
Thank you, Roland, for this very interesting data. Michel?
Roland, thank you for this nice presentation. On the slide where we show patient preference, there is something that you skip. Those on 0 med and 140 also had, and we knew this from solo trial and as seen from spiral off med trial. Patient didn't want to take antihypertensive medication and participated to the trial. Could you comment there? The willingness, even from milder form of hypertension with 0 med.
Yeah, I think this is also a very, very important group, in particular those who have not taken medication or have firstly diagnosed hypertension. And in our German survey, there were 37% willing to have renal denervation in taking a drug lifelong. And we must be careful looking at that, because you know what the patient is doing? Yeah, he prescribes some drug. He doesn't come to the doctor. He says, well, hypertension, it's not so dangerous. So we should be very carefully looking at these kind of patients. I totally agree, Michel.
Professor Palatini.
My question is to Dr. Azizi, also to Dr. Smith. So you presented average data, but I'm sure that among the patient you found some good responders, but also patient resistant to the technique. So I wonder whether you could work out some list of good predictors of the response. And perhaps in the next clinical trials, you could select patients according to these predictors.
This is really the $1 million question, I would think. But well, let's just summarize where we are. We have a list of predictors, of potential predictors, to be clear. And so far, there's only one predictor, and that's the level of the pre-treatment blood pressure. The higher it is in the beginning, the greater is the response. That's all. But this is with all kind of intervention you do. If you have a high LDL cholesterol, you have a greater fall, and you have only a middle increased. All the other factors, age, or vascular stiffness, or plasma running activity, all kind of parameters overall, did not have such a power that it enabled us to make a personalized medicine approach in terms of predicting the response.
But there is a good predictive capacity for a heart rate, I guess, from the trial. So if you choose an ambulatory heart rate, for instance, I think that could be a discriminant.
I agree on that, and if you look that in the trials, heart rate indeed came out, dividing patients with a median above or below the median. When you look at the blood pressure, there's a significant difference. So this just confirms the concept that we intervene with the sympathetic nervous system in terms of reducing the sympathetic drive overall in the body. But to say, well, if a patient has a heart rate of 80, let's put it that way, and a patient have only just a heart rate of 65, to make an individual precise prediction about the blood pressure response, this discriminator is not strong enough.
This is the problem of group approach and individual approaches. So we're testing among the groups. So, and yes, we find correlation and things like this, but then we have to apply to the patient, and it's tricky then where we want to apply directly. And this has been done also for drug therapy, where we looked 1,000 studies to look what was how the patient respond to diuretics, to ACE, ARBs, etc., to find predictors, because as you know, when you expose patients to medication, you have around 50 to 60% of patients who are responders, and they are non-responders if they take the pill. If they take the pill, you have an additional problem here. And looking to all the parameters, nothing came out, to say, okay, this one should receive this. No.
I think one final comment, I think also, what is the explanation for that? That's the point. We have a heterogeneity of the pathophysiology of so-called primary hypertension. But the primary is not a homogeneous disease, it's a heterogeneous disease. So you can expect that there are various subtypes, and some may profit more or less, but we have not succeeded to have these subtypes separated, so unfortunately.
If I could, in line with what Michel just said, that in order a drug to be effective, the patient has to receive, also in case of renal denervation, we have to do an effective procedure. That means that they have to follow, let's say, the therapeutic algorithm according to the specific device that, according to the trials that have shown this blood pressure reduction. In other words, this procedure is a rather simple procedure, but has to be performed by experienced operators and to follow exactly the algorithm of delivering the energy, ultrasound or RF, whatever it was used.
To add on your comment, Kostas, is yes, when a drug enters the clinical phase, after PK, PD, pharmacokinetic, pharmacodynamic studies, where the amount of drug present in the body is associated with a certain effect. So here, not only this is very important that we do the interventionalist, I'm not interventionalist, do the right procedure, but the problem we have, and specifically interventionalists, is there is no feedback. They don't know whether, the depth.
It's a blind procedure.
It's a blind procedure. This is one of the issues there's no stenosis that you relieve. And I leave you a comment on this more specifically because
For this reason, we are obliged, let's say, to follow exactly what the randomized trials have shown, to follow or to ablate by using this specific catheter, for example, just now the paradise catheter, ablate in the main stem, follow all the steps according to the protocol in order to achieve, to reproduce the results that the studies have shown, at least at the population level. At the individual level, up to now, we don't have any way to be sure that we have effectively ablate the appropriate number of fibers.
So this is also has been shown in experimental models. That is, okay, using this type of procedure, when you go do this, you have the ablation the depth of the ablation is sufficient, and usually when you look to the renal arteries and the fibers, there have been a complete necrosis of the nerves. So this is why in extension it is done like this, but still I think we are missing something that, for example, for AF, you have this, you can stimulate, verify whether you make the ablation.
No, even for AF, this is not a good example for coronary artery stenosis.
I'm not AF,
Well, on the other hand, AF is not too bad because there, if you look after the 1 year data, you may have a success, you say 67% after 1 year, but still 30% are non-responders even after first AF, despite the fact that immediately thereafter, in the cath lab, you have proof that you've done a good job. So it's also there, it is not so simple with AF.
Roland, you mentioned in your slides on the long-term follow-up that these people are going to be followed with office blood pressure only. Why don't you include also home blood pressure?
I think this is a plan to also go for home blood pressure measurements, but of course you need the compliance of the patient, but it will be done.
It should be very easy, and it would be a waste not to do it, you know, given the evidence we have.
It's pursued.
We have already had a nice general discussion with this speaker. You are not failing. You always find some discussion. Can we have, please, the last slide for last topic for the general discussion? Here you see, next please, the next one. 3 clinical cases, just to do some brainstorming. The patient A is a 67-year-old male, hypertension diagnosed 10 years before, uncontrolled for 4 years, office blood pressure elevated, treated with 4 drugs, and is a retired guy, obese, with untreated glucose intolerance, and he claims to be compliant with medicine, but is not achieving a target. So there could be an example of resistant hypertension. Then you had case B, a 50-year-old female, hypertension diagnosed 5 years before, uncontrolled for 1 year, office blood pressure still elevated, treated with 2 drugs, had a TIA 2 years before, plant manager, shift work with some problem with the sleep also, you can imagine, frequently forgets medicine, and she does not have any major changes in the blood test. Last case, 50-year-old male, hypertension diagnosed 7 years before, became uncontrolled recently, office blood pressure is elevated, treated with 2 drugs, it's a truck driver, irregular working schedule, problem with day and night, and he does not want to take pills because this is causing frequent urination as to drive, so he does not want to be treated in this way. He has type 2 diabetes, high cholesterol, is a smoker, quite a high risk profile. So, next slide is a question here. What would be your choice? Would you recommend ultrasound renal denervation in patient A, B, C, all of them, or none of them? Please give us your opinion. These are typical cases that we see, obviously, in our daily practice. They are not so rare in our experience. Okay, so the majority is divided between patient A, so the resistant hypertensive guy, let's call it in this way, or all of them. So let's make a round here. Starting from Costas. What would you do, Costas?
Ideally, I would start it.
Go back on
Can you go back to present the 3 cases?
Ideally, I would start from patient A because always we have the challenge to treat the higher the baseline systolic blood pressure. We know that this is, let's say, the best response. So for this reason, I would select patient A. Also, he is suffering from resistant hypertension, although receive the fourth choice. So this should be my first priority, but also I couldn't offer renal intervention to other two patients. But my first choice would be patient A.
Michel?
My two first choices would be A and B, because B also has a complicated hypertension for someone who is 50 years old, complex life, forgetting medicines, etc. When we discussed on what you said, that this is a combined approach here, each millimeters of mercury that we will gain for this patient will have an impact on his future prognosis. So I would treat all of them, but with a preference on A and B.
Roland? For me, these three patients are candidates for renal denervation. And I have not seen here such open measures of objective adherence or non-adherence. So what is missing here for me is that we do not know any information about the patient's perspective. But with patient B, there is already becoming clear that he cannot manage himself his disease at the moment. And with patient A,
sorry, Roland. The question is who will offer renal intervention? It's a second question if the patient would accept or no.
Good. 2 or 3, period.
So you choose for the patient and you don't leave him the possibility. I understand how it works.
And another piece of information missing here is out-of-office blood pressure, obviously, because we have to confirm that this is really something they cannot control. That's important, just in case. So you see there is still some debate, and we need to learn more. The identification of the ideal candidate is still a matter of discussion, obviously, but this is one of the perspectives we have to address in our future studies. We have to close now because it's a bit over time. Michel, you never silent.
Just one word, because seeing what you answered here, also as specialists, because you're a specialist in this room, I think, as all, we have the responsibility also to convey the message to other physicians. So you have integrated this in your brain and probably to prescribe also to go to centers where renal intervention can be done. But also the message has, and your ambassadors somewhere could convey the message also in other settings and specifically with your colleagues, GPs or other specialists. So this was, I wanted to add this.
Thank you, Michel. I really have to thank all the speakers for their excellent talks. Thanks for Record for organizing this interesting session, and we still have something to learn, as you see, but we have nice perspectives for a better hypertension control. Have a nice day.